Good afternoon, and thank you for joining us. I'm Julia Harris, an Associate Director of Health Policy at the Bipartisan Policy Center. Today's event will focus on remote patient monitoring, which refers to the use of digital technologies to collect and relay patient data to healthcare professionals. One common example is a home blood pressure cuff. This field of remote patient monitoring is really at a turning point. The percent of patients using remote monitoring technology is relatively low, but quickly increasing. Medicare, most state Medicaid agencies, and many private health insurance plans cover these services. And just this month, the American Medical Association proposed a significant revision to remote monitoring billing codes, reflecting the growing importance and complexity of these technologies in healthcare. One discussion today, we will delve into these complexities. This event builds off of a year-long project done in partnership with the Peterson Center on Healthcare to assess how patients and healthcare providers are using remote monitoring technology and its impact on health outcomes and cost. BPC has engaged with a diverse group of stakeholders, including policy experts, federal officials, medical providers, and payers. And last week, we released a comprehensive policy recommendations to enhance the use of these technologies. You can find our report on our website at bipartisanpolicy.org. Remote patient monitoring has the potential to transform disease management, especially for patients with serious, uncontrolled conditions. It could also expand healthcare access for underserved populations, including those facing mobility challenges and rural residents. But right now, access to remote monitoring is often based on where a person lives and who their provider is, rather than which patients stand to clinically benefit. Some experts worry that we don't have sufficient clinical guidelines to inform how to best use these services, such as for which patients and for how long. Without these guidelines, we risk either underutilizing these services and denying patients care, or overutilizing them, leading to unnecessary spending and overutilization. Now is the time for payers and providers to optimize the use of these emerging technologies, and the recommendations in our report fall across three major categories. Our first set focuses on service coverage, where BPC calls for clear clinical guidelines on who should use these services and for how long, more flexible billing options for medical providers, and an expansion of remote therapeutic monitoring codes to include a broader range of conditions. Our second set of recommendations focuses on ensuring high quality and equitable use of remote monitoring services. We recommend policies to enhance access for underserved populations and require device labels to include information on performance across demographic groups. The last set of recommendations focuses on patient privacy and security. We call on HHS's Office of Civil Rights to communicate whether there are gaps in privacy protections, and if so, either fix them or call on Congress to do so. With this context in mind, I'm now delighted to introduce Caroline Pearson, the Executive Director of the Peterson Center on Healthcare and the Peterson Health Technology Institute. Caroline's expertise and the Institute's dedication to evaluating digital health technologies have been invaluable to this discussion. Thank you, Caroline, for joining us today, and to Peterson Center on Healthcare for their generous support of BPC's work. I'll turn it over to you.
Thank you, Julia. I'm really delighted to be here today. Our mission at the Peterson Center on Healthcare is to make higher quality, more affordable healthcare a reality for all Americans. In most sectors of the economy, technology has driven down costs and improved efficiency. Yet in healthcare, we have countless examples of technology doing the exact opposite, increasing costs and complexity with unclear patient benefit. Digital health technologies have grown rapidly over the last 10 years and were really accelerated by the COVID pandemic. And this presents an enormous opportunity to improve health outcomes, improve patient experience, and increase affordability. However, as we gain experience with these tools, we need to look closely at the evidence about their performance and use that information to drive decisions about our investments. Payers, providers, and patients need to understand, do these tools work, for whom, and at what cost? And that's why the center launched the Peterson Health Technology Institute as an independent evaluator of health technologies, including remote patient monitoring solutions that we're discussing today. PHTI assessments will focus on products' clinical effectiveness and budget impact, as well as the user experience, health equity, and privacy and security. Our first two reports will come out in March, and they will focus on digital diabetes management solutions, including those using RPM, and virtual musculoskeletal care. And we'll be announcing more topics soon, so stay tuned. And our goal is really to raise the bar for better digital health evidence generation that informs purchasing decisions. As more patients gain access to these digital health solutions and technology-enabled care, we know that there's a tremendous demand for this information for both public and private payers, including employers, Medicare and Medicaid managed care plans, and federal policymakers who are responsible for covering and paying for these solutions in traditional Medicare. And that's why we're so excited about this BPC report that takes a deep dive on RPM policy issues. And we look forward to adding to the body of evidence on digital health with our forthcoming assessments. The Peterson organization has been a longtime supporter of the Bipartisan Policy Center. We've been so pleased to partner with Marilyn, Julia, and the entire BPC Health team over the past 3 years as they've produced timely and insightful reports on the state of telehealth and now remote monitoring. Today's panel includes accomplished experts in the digital health space, and we thank each of you for your time and insights, and for all of the great work that BPC has done on this report and on this webinar. And with that, I'll turn it back to Julia and get our conversation started.
Thank you, Caroline. All right, well, I'm actually going to quickly pass it off to Anuja Vaidya. Anuja is a senior editor at Xtelligent Healthcare Media. She's been reporting on digital health for over 7 years, and she's going to moderate today's discussion. Anuja?
Thank you, Julia, and the entire team at the Bipartisan Policy Center and the Peterson Center on Healthcare for this opportunity. I'm thrilled to moderate this discussion. Now, during the event, audience members may submit questions using the YouTube chat function and through X, formerly known as Twitter, using the hashtag BPCLive. Now, let's go ahead and meet our panel. First, we have Dr. Devin Mann. He is an internal medicine doctor and the strategic director of digital health innovation at NYU Langone Health, where he runs an RPM hypertension program. Dr. Ateev Mehrotra is a professor of healthcare policy and medicine at Harvard Medical School. His research focuses on digital health innovation, including the impact of remote patient monitoring on healthcare quality, cost, and access. Brendan O'Leary was the founding deputy director of the FDA's Digital Health Center of Excellence and served as the center's acting director. Kara Tenenbaum is the founder of Strathmore Health Strategies, a consulting firm that focuses on digital health and other patient-focused regulatory issues. Now, before we dive into questions for our panelists, I want to play a short video of a patient who used remote monitoring technology. Ebony Ford is a maternal health advocate, a certified patient family partner with the Preeclampsia Foundation, and the founder of Miracle Mamas. She was prescribed a remote blood pressure cuff after being diagnosed with preeclampsia while pregnant. Let's hear Ebony's story.
In 2022, my husband and I decided that we were ready to expand our family again. And in 2017, my husband and I found out that we were expecting our daughter. And our pregnancy was completely uneventful until the 25th week, where I began to experience swelling in my hands and my feet. I went into my doctor's office and expected to see my regular doctor. Unfortunately, I saw a partner, and I began to explain all of the symptoms and the things that I was feeling. Despite having multiple risk factors for preeclampsia and a few other conditions, they said that I was fine, that everything was fine. They didn't see any issues with my numbers. I didn't need to do any additional blood work, and that I was cleared to go on a trip in just a few days. So I took their advice. I went on my trip. First day, I felt fine, but the second day, I began to experience some visual disturbances. I also had increased swelling in my hands and my feet, and I overall just felt very winded and felt like I couldn't breathe. So I reached out to my doctor and explained what was going on with me, and her advice was to hurry up and come back home. So we altered our travel plans, and by the time I arrived at the emergency room at our hospital, my blood pressure was 262 over 154. At that point, I felt like I could not breathe. I had issues with my vision and was extremely afraid of what was happening. After a short time in the emergency room, they explained that I may have something called preeclampsia. While settling into that reality, a totally different care team came in and explained that not only did I have preeclampsia in its severest form, but I had something called HELP syndrome, a term I had never heard. They began to explain that I was in kidney failure and in liver failure, and that the only cure was to deliver my daughter immediately. So at 26 weeks and 5 days, my daughter, Rain Victoria, was born by emergency C-section. She weighed 1 pound, 15 ounces. I then went on to the ICU, was put on life support and dialysis and many other life-saving measures to hopefully allow my organs to heal, my body to heal, and to allow me to see my daughter. After 3 days, I was taken off of all of the machines and was wheeled down to see my daughter. In 2022, my husband and I decided that we were ready to expand our family again. And in October, we found out that we were pregnant with our son. I knew that this time I needed to do something different. I knew that the odds were against me to have preeclampsia or HELP syndrome again. And I also felt that I needed a different care team. And so that pregnancy was completely uneventful. And we got past 26 weeks, which was our ultimate goal, which is when I delivered my daughter. But unfortunately, at 28 weeks, I began to experience signs of hypertension. I also began experiencing protein in urine, which are telltale signs of preeclampsia. And so at my doctor's appointment, my doctor came in with a box and he explained that this blood pressure cuff would report all of my readings, not only to him, but also into the patient portal so that he and I could both see the same numbers and so that they could foster conversation about what the next step were. He explained that I would need to use this cuff 3 times a day in conjunction with staying in contact with him and the nurse, just to let them know how I was feeling and that I needed to journal what I was eating and my symptoms during the day. So after 3 days of taking my blood pressure 3 times a day, I got a call from my doctor stating that my numbers were still a bit too high and that it was time to get onto medication. And my numbers were okay for a few days, but they began to raise even more. And so I was brought in for an ultrasound where we discovered that my son was growth restricted. He was in the 6th percentile for growth, and there were also some issues with blood flow through his umbilical cord. I was admitted into the hospital at 30 weeks pregnant, kept there to keep an eye on his Dopplers, on his heart rate, as well as my blood pressure. I was put on magnesium to help regulate the signs and symptoms of preeclampsia, but it continued to advance. And at exactly 31 weeks, my son was born weighing 2 pounds, 14 ounces, and was taken to the NICU. But this time, I was able to see my son immediately as my condition was not as dire. And I truly believe that is due to, one, me picking a new care team, and then two, having access to life-saving care, such as a remote blood pressure cuff. I honestly believe that this fostered an amazing amount of communication. It helped me to stay in touch with my body and what was going on, and I was able to come into the hospital a lot sooner. This blood pressure cuff, although a very simple device, was beyond life-saving for me. It's a simple device, and they're very simple instructions, but it has such huge implications and such a huge role in our healthcare, especially for pregnant women who have hypertension or who've experienced preeclampsia in the past.
Thank you, Ebony, for sharing your powerful story with us. Now let's turn to our panelists to explore opportunities and challenges in remote patient monitoring that Ebony's story has brought to light. So Devin, we just heard from Ebony about remote monitoring for hypertension to monitor her preeclampsia. You actually run an RPM hypertension program at NYU Langone. So I would love to hear your reactions to hearing her experience. And do you see similar patients?
Yeah, I mean, honestly, that story, warms my heart because those are exactly the patient stories we love to hear. That's why we've all been spending so much time really for 6 years now or so to set up this kind of just capability across our institution. High-risk pregnancies, whether it be from preeclampsia or gestational diabetes, these are really obvious, what we say, low-hanging fruit, things where, simple technologies can just connect patients and the doctors in a much sort of more intimate way where we know what's going on without them having to come and disrupt their lives every couple of days or become inpatients. these are obvious things that we should be accelerating, and we are here at our institution, but as was mentioned early on, that's not evenly spread around the country. So we're fortunate to use that broadly here, but I'd love to see that used elsewhere. And just following up on that, that's like the most obvious places, but the technology actually has so many other applications for high blood pressure across, regular adults and kids, all sorts of seniors. We can find these real opportunities, and we are. I mean, this is happening now. We're really emerging, as was noted earlier on, out of sort of a background, organic, let's see where it works, to like, okay, this works. How do we make this sustainable in every aspect of our healthcare delivery system?
Said these are very simple, very obvious technologies, most of which we already have. So Kara, could you describe some of the kinds of devices we're talking about when we talk about remote monitoring technology?
Sure. Well, first of all, thank you for asking this question. Thank you to BPC and the Peterson Center for doing this important work. So to start with, when we're talking about remote patient monitoring, there are two main categories. There's remote physiologic monitoring, which is devices that are collecting physiologic data from the body, like the blood pressure cuffs that Ebony talked about, scales, pulse oximeters. These are things that are taking the data, they're monitoring them, and the patient doesn't need to be involved generally in moving that data. They are transmitted maybe like through Bluetooth or to the electronic health record, so the provider gets them. The other kind of big category is RTM, remote therapeutic monitoring. That's much more based in software. There are 4 specific categories that Medicare pays for right now in the musculoskeletal area, like remote physical therapy, respiratory. So some people might blow into these spirometers to measure how well their lungs are doing. And then 2 parts of cognitive behavioral therapy. So really, we're only looking at these 2 things right now in terms of what Medicare covers.
Got it. And, I'd love to kind of discuss now who is using these technologies. So Atif, you've done a lot of research on remote monitoring technology. So could you tell us who has access to it today, and what are some of the most promising uses you're seeing of remote monitoring technology?
Yeah, as Julia said when we in the introduction, it's growing rapidly, but it's relatively targeted. So there are a relatively small fraction of clinicians who are using this. What we've seen so far is the common uses, as was already articulated by Ebony's story and what Dr. Mann said, which is that blood pressure monitoring is the most common application, and then diabetes number 2. And then after that, we see an array of other applications. But I think more importantly, we're seeing it largely in primary care and again, select pockets in the country, as opposed to available to all Americans right now.
Got it. Devin, I'd love to hear your thoughts on whether there are any potential limitations, of the research we're seeing in this area right now.
Limitations, sure. There are limitations on, I think, on a couple fronts. One is technological. Kara alluded to the Bluetooth technology, and sort of how hard is it essentially to get the information off the machine in my house to the doctor's hands. And surprisingly, even in 2024 now, it's still harder than it should be, with lots of opportunities, especially for folks who aren't necessarily digitally savvy, to get that information in there. And that's a struggle that we're working hard on, but there's a lot of room to go. 2 is on the clinical side. Let's say we have all the people who we think, all the Americans we think should be doing this, sending in that information. Are we set up on the healthcare system side to receive that all information? Do we have the people to receive it? Do we have the best practices of what to do with all that information? Not quite yet. So there's a sort of, we're building the plane and flying at the same time experience where we want to see more of this, but we also need to figure out how to deal with this if we actually get what we want. And the third part that I think was alluded to earlier is sort of the financing system that supports both sides, so that patients can send that information easily, and that we can monitor and take action on that and be reimbursed for that time. That's still in evolution as well. So all 3 present challenges, but I think we've made progress, and I anticipate with folks like BPC and the Peterson Center helping, we're going to make more progress in the coming years.
Absolutely. And I definitely want to dig into some of these challenges a little bit more. But before that, Brendan, I'd love to hear from your perspective. What are some of the most promising uses of remote monitoring technology that you're seeing right now?
Sure. And I think, one takeaway from Ebony's experience that she shared with us was that this is an example with remote monitoring where the whole can be more than the sum of the parts. What she said there about having the same numbers, seeing the same numbers as her care team and how that fostered communication, we can get caught up in individual technologies and individual use cases and get really specific about where these benefits are. But there are also these cross-cutting benefits in terms of the patient-provider relationship that I think it's really important to keep in mind here. And remote monitoring, honestly, I think is going to be a big part of the new bedside manner of the digital age here in medicine, and something that we need to be thinking about on a much larger scale in terms of how patients can benefit from it.
Mm-hmm. Absolutely. And now I want to delve into some of those challenges a little bit more. Devin, you already kind of discussed some of these, and we also know other challenges like access to remote monitoring technology is really based more on where a patient lives or who their provider is, rather than maybe the patients who would stand to clinically benefit the most from using these technologies. So in addition to what you mentioned before, could you highlight some of the biggest challenges for providers to adopt these types of technologies and these programs and actually, enable their patients to access them?
Sure. I think that they're really sort of additions to what I've said already. So to get more detailed, the reality is we all know that the clinical system, a lot of the providers, there's a burnout problem, right? Because people feel overwhelmed with the amount of data, particularly post-pandemic, where now we're getting messages. And we love that. We love communicating with our patients, but there's a limited number of minutes in the day. And it takes time to look at all this data coming in, put it together, and make an action plan. So that is a big barrier, particularly in communities where, let's say, the healthcare system or the providers there are particularly burdened, right? So often the hardest places to work are where the providers and the patients need more time and more effort. And so that's where these new technologies, we have trouble for them taking root. We've spent a lot of effort here in New York trying to improve those situations because we have a lot of these communities we want to help. And there are ways to do it, but that is a real barrier that will need to be done and dealt with. And I think you alluded to as well, which is, everyone's from all these different backgrounds have a different relationship with technology. One, trust in technology. Two, familiarity and how they interact on an individual or community level. All these things really need to be sort of sorted through, and we need to tweak how we do this to really engage everyone equally so that everyone feels like they have a fair shot at using this life-changing technology that Ebony took advantage of in her experience.
One thing I'd love to jump on what Dr. Mann said, which was that it's, Ebony made the very accurate, reason point, which is this is a pretty simple technology, and others have echoed that. But I think for me, the reason that remote patient monitoring can be such a big deal is it really changes the paradigm of how clinical care can be provided. We have a clinical system that's a very reactive system. I wait for my patients to get sick, to call me up, and then I will act upon that information. I wait for them. And as Ebony described, remote patient monitoring allows us to go to a proactive system where we're actually monitoring some key information. And when things are awry, we call them. And so that really feels, for me, for chronic illness, as a real fundamental shift in how we provide care. But it's a big change in how we deliver care, and the issues that have already been described in terms of how we change clinical practice are really critical as we adapt.
Right, absolutely. And I think as has been mentioned, these are, fairly simple technologies, but I don't want to assume that all of these technologies are as, completely simple for every single patient who might use them. So Brendan, I'm curious, do you think there are some maybe more worrisome, maybe less proven applications of the technology that we do kind of need to be wary of, as the field continues to grow?
Well, I think, simple is a dangerous word here. And what's simple for one patient or for one user is not simple for everyone. And, we have good frameworks in place for ensuring the accuracy of these technologies for their intended use, ensuring that they're fit for purpose, that they're going to measure what they say they measure with appropriate tolerances and help us make good clinical decisions in our healthcare system. But people have already highlighted here, the challenges with getting Bluetooth hooked up to a smartphone, if you even have a smartphone to use with this, the barriers that the digital divide puts on us here. My personal perspective on that is that this technology is going to advance faster than our healthcare system typically advances on its own. And so, these are problems that we're on our way to solving and need to move faster to solve, but that there's good room for optimism here.
Right, right. And I think part of the problem too is that, there really are no clear clinical guidelines for all the applications of remote monitoring, as BPC's report highlights. So Kara, I'd love to hear your thoughts on how we can make sure these guidelines are created and that they are actually clear to providers.
Thank you. So like Brendan talked about, a lot of these devices, and they are supposed to meet the medical definition, the FDA definition of a medical device to be covered by CMS. And that means that FDA's evaluated them to see if they do the thing they're supposed to do. That doesn't mean that they're being used the right way, right? The practice of medicine is completely outside of FDA's purview. And so what we see, we see this in the drug space. NCCN with their robust guideline development for cancer drugs, is a great example. And so what the report suggests is that maybe medical societies can work with federal agencies. Could there be guidelines that, the OBGYNs work out on who should be monitored while they're pregnant? There's a study in the report about the utility of RPM and blood pressure. And what the study shows is that generally within about the first 4 months, you see the benefit you're going to get. Well, if there was something that both, encouraged providers to use RPM tools for people who have hypertension, but also say, this is how long you should be monitoring for. And at, 4 or 6 months, you stop if you're not getting a result, or this is what you do. Just like we have, if this medication doesn't work, then you go to this. And it's not prescriptive, but it provides guidelines so that medical providers can do more of what they should be doing, right? We're seeing both kind of a potential underutilization and a potential overutilization of RPM. And so creating these guidelines could really right size the use of these tools.
Right. And to your point, I think that really is the key, right? Making sure that the people who need the technology have access to it at the right time, at the right place. And instead, on the other hand, we do have some reimbursement, sort of like constraints tied to reimbursement, which is kind of interesting to note. And I would love to get Devin's opinion on this. So right now, we do have remote monitoring billing codes that require healthcare providers to gather data for 16 days and then spend 20 minutes talking with a patient each month. So how do these requirements really affect clinical care, and would you change them?
Yeah, I mean, I think they do have an impact, right? Particularly in places where, billing is still really important for keeping the operations running. When I talk to my colleagues across the country leading other programs, most of us are not really doing much reimbursement. We're not billing all that much for this service because we're still figuring it out. We're trying to understand how to really deploy it and make it work for everyone. And the reality is reimbursement's kind of low and relatively onerous compared to other things. So just being very transparent, when you have a situation where it's kind of hard to do the billing, it doesn't bring in that much revenue, and the clinical service is still being figured out, it's not a very active area on the billing side. So if we made it a bit less onerous to do the billing, I think that would be an improvement. We'd have to find the right balance of sort of reimbursement versus value, and that's something that the BPC I know is really thinking about hard. And then figuring out, essentially how to do this service well. Like, so the research we're talking about, really figuring out which patient populations benefit the most. All three will have to come into play. But I would love to see movement in all three spaces. And as a healthcare system, obviously, making the billing part not the obstacle, is how we view things. We want to deliver the care, understand that, things are more complex than that. But I think that's where we'd like to see it move in partnership with, the federal government and other policymakers.
Absolutely. Atif, what are your thoughts on this? How does this sort of reimbursement model that we have right now impact, the actual delivery of care?
Yeah, I think just to first emphasize a couple of points, not surprisingly, and it's been said a couple of times, but just want to emphasize it, that we see remote patient monitoring being underutilized, and we want to target it to those patients who have uncontrolled illness or really high risk situations. But we're also seeing remote patient monitoring being used for patients who are doing really well with their chronic illness. And not surprisingly, if you're doing pretty well, you can't, adding this on top of that is not going to be beneficial. And so I think some of the billing situation is sort of encouraging this low value use of where it's being used for. And that's because the current billing system encourages a clinician to do it for as many patients as possible, because it takes so much investment to build the infrastructure. And after that, you're going to try to get as many patients on it as possible. So I'm overall supportive of the idea of more targeted use of it, but that's going to require some increased reimbursement from my perspective for those patients who use it, because you need to maintain this infrastructure. And in regards specifically to the question, Anuja, about how many days you bill for, I think there needs to be more flexibility. It's a relatively crude way of trying to, it's not flexible enough to address the variety of clinical circumstances that this is going to be used for, and we need more flexibility so clinicians can use it appropriately.
Absolutely, especially given that, we're still really uncovering the various ways in which we can use these technologies. So absolutely, there does need to be those models that are a bit more flexible. So kind of keeping in line with that, Athiva, I'll stick with you. What are some of the steps that policymakers should, take to build off of the evidence and really kind of optimally target the use of these services?
Yeah, I think it is, again, that just a really fundamental shift to saying, look, there are certain patients out there who are going to really benefit. And how do we figure that out? We're going to both use clinical guidelines as articulated in the BPC report, as well as I do think that simply making a very simple attestation from the clinician saying, look, this is why I'm using this technology. And I think just those simple checks can really target that kind of technology to those patients who are going to benefit most.
Mm-hmm. Absolutely. Kara, Brendan, I'd love to hear both of your thoughts on this as well. What can policymakers really do to make sure that they're building from the evidence that we have and right-sizing, like Kara mentioned, the use of these technologies? Kara, why don't you jump in first?
Sure. So I'll start. Thank you. I think one of the things we need to do is follow the science here. And I think that part of the gap is that we don't have a lot of data. Like Brendan said earlier, this is a really fast-moving technology. And kind of as he alluded to, the medical system tends to work a little slower getting evidence into practice, right? And so what we need to do is really build the evidence base, figure out who needs these tools, when, how long they work. Because right now we're kind of flying a little bit blind, and we're hoping, and we are really I think Atif said this earlier, we are really building the plane as we're flying it. And so making sure that policy follows the science is kind of the number one thing that we need to do here. And so we need to build up that science and evidence base.
And to add on to that, I would say the BPC report does a nice job of laying out some recommendations on how we can think about reimbursement for this and avoid sort of the wrong incentive structures in terms of numbers like 16 days or 20 minutes that may not be right for every clinical condition. I also, Atif made a good point about the chronic condition patient who's doing well. And I want to remain open to the idea that the chronic condition patient who's doing well might do well for longer with remote monitoring. And so certainly we know that this can help in a number of cases, and we need to be open to the possibility that it can be helpful in a broader set of cases. And as the policy moves forward here, it's absolutely right. It needs to move with evidence, and we need to be moving in a way that allows that evidence to be gathered so that we can evaluate those questions.
Right, absolutely. And now I want to spend a little time just delving into the devices themselves. So, we've seen sort of an explosion of medical devices, of, health applications, wellness applications. So Kara, could you just briefly describe what devices and services do not fall under remote patient monitoring?
Yeah, so I would love to spend a lot more time talking about devices and apps and where the evidence is and isn't. But for now, let's talk about just kind of the Medicare bucket, right? Of what gets reimbursed by Medicare, and the tool has to meet the FDA definition of a device. So that means most of the things like your average Fitbit or Apple Watch won't count, except that there are apps that are cleared and approved for things like Apple Watches that are medical devices for things like atrial fibrillation. We're also not talking about, so that's kind of the wellness category, right? Your step counters, that kind of thing. But we're also not talking about the electronic health records, right? And Ebony's story was a great one where the provider was getting the data through the electronic health record. So that kind of stuff and the platform on which you get those data is also not covered by this. And we've heard from a lot of providers that patients are manually putting in those data, right? So those don't fall under this RPM, RTM category that Medicare pays for. And then I think the other thing just to point out is, again, that when we were doing our research, that CMS requires that these tools meet the definition of a device, but they don't actually require that they are reviewed or cleared or approved by FDA. And that's a really small fix that the report recommends that Medicare could fix, and make sure that these tools do, as Brendan, said earlier, do what they're intended to do.
Mm-hmm. Right. And I think what can, further complicate things is that it's really difficult to find accurate information about remote monitoring devices. I mean, the field is also just moving so quickly, and new solutions, new apps are just popping up. And also FDA cleared or approved devices do not always include, detailed performance information. And there's no real central database to search for these devices. So, Brendan, how can the FDA promote the adoption of safe remote monitoring technologies?
Yeah, and here again, I think the report lays out a couple of nice solutions that you've alluded to. Certainly, the public information on the FDA's website could be made more user-friendly. That's an easy statement to make. It's always true. And I know that there are good people there working on issues like that. Similarly, to a point that you raised, sometimes it's hard to figure out what's cleared and what's not. It's hard to understand exactly how well you can expect those technologies to work in various situations. And I think that leading manufacturers are actually starting to catch on to this and do a much better job in their labeling, in the summary information that they submit for inclusion on the FDA's website, and in other contexts of really describing how they've validated their technologies, what patient populations they've studied them in, and how well characterized they are. It's probably not reasonable to expect that we'll be able to get to a point where you can do easy head-to-head comparisons of one product versus another. That's just a really difficult type of study to run. But we can get to a point where we can be really confident that these technologies are good enough for what we're trying to use them for. They can be well characterized, we can shrink the confidence intervals, and we can get to a point where we can really be confident that we're deploying them in a sensible way and relying on them for the right questions.
If I could jump in, though, we've seen that there are some tools like pulse oximeters, right, which do what they're supposed to do for people with really pale skin, and people with darker skin, they don't work, right? And so I don't know that that's in the labeling, and it's certainly something FDA has addressed over the past couple of years, I think with COVID and home use of pulse oximeters that really came to the front lines. They're having a big meeting on it. But you have these kind of smaller subgroups and populations that we don't have in the label and we don't have tested. And so as we think about a wider use of, these home devices or all of these RTM and RPM tools, we really do want to, think about the diversity of people in the United States and who will be using them and who they work for.
Mm-hmm.
And the only thing else I wanted to build off this conversation is that this is both a positive and negative. The positive is I'm just amazed by all the different clinical areas where people are developing devices that can help better monitor their illness. The negative is there's so many different devices that are coming out in the different clinical areas. And as Kara said before, we have several applications for remote therapeutic monitoring, but I imagine in the future we'll see a much broader array. And it's a balancing act. We want to encourage that innovation, but we want the evidence that it works. And we also don't want to overwhelm the clinicians by having 74,000 codes that they have to choose for this application. So how to balance those different issues of administrative burden and clinical applications is, I think, is a really important one. And I think why this conversation is so critical.
Mm-hmm.
There's one more,
Right.
which is the validation by the FDA is critical. It gives us a sort of a minimal amount of knowledge that this device in the perfect settings works. You just have to remember with RPM, this is happening in homes. So it's never going to be a perfect setting. And often even the gold standard is not perfect. So blood pressure, good example. We're like, oh, as compared to the measurement in the office. Actually, the measurement in the office is really flawed. People are often in our city running across town, running up the stairs, trying to get in, sit down real quick, put a blood pressure cuff on. So it's, needs to be rechecked and often still abnormal. So we rely on the FDA to at least tell us that the device sort of in the good situation works. Beyond that, I wouldn't spend an enormous amount of energy. There's going to have to be a lot of adaptation locally with the clinicians and the patients and understanding that context because it gets real complicated real fast.
Mm-hmm. Mm-hmm. Absolutely. And, speaking to your point about not adding to administrative burden, there's also the question of the amount of data that is being collected by these devices. And that kind of leads me to another point I really want to, get into before we turn over to audience questions, which is the privacy and safety of this data that is being collected by the devices, which is something that BPC discusses in their report. So, Kara, do the existing privacy policies appropriately protect patient data collected by remote patient monitoring devices?
So I think people are trying. I think when laws like HIPAA were enacted, it was before even people thought of this kind of idea. There is cybersecurity built into, FDA review, which I think Brendan probably knows more about than I do. If you think of data as water through a hose, right? There's like, all the hoses match, right? That's kind of your interoperability. And the cybersecurity is making sure that the water there's no leaks in the hose itself. But what we heard from folks doing this report is that connector where the connection, right? Have you ever gotten a leak there? We still have that gap in some of these data. So where the data are uploaded, where they're not protected. And then of course, there are always going to be bad actors out there who are, it seems one step ahead of the white hat folks. So I think privacy is ongoing. I think that Congress is really paying attention to this. The Federal Trade Commission, the Office of Civil Rights and HHS, folks are talking about this and they're paying a lot of attention to it. And so I'm optimistic that something good will come in the next couple of years.
Fantastic. Devin, I'd love to hear your thoughts about this as well, especially with that provider perspective. How do you think patient privacy, current patient privacy policies are set up? Are they really doing what they're meant to be doing?
It's a big question. I mean, I don't want to comment on all patient privacy policies. I think that's a bigger question. But in the RPM space, I think we take a view of we really do want to protect information. There's a certain trust here, particularly as a healthcare provider. When patients upload that data, they think I'm the one looking at it, me and my colleagues. We're not reselling it. It's not going to end up in some big leak. So we take that very seriously. And honestly, this is one of those situations where we appreciate when sort of the policymakers kind of create very clear ground rules, because we engage a lot of industry vendors and, it takes a lot for us to evaluate each one and what their security stance is and all those kinds of things. So to essentially level the playing field, say everyone who wants to play here with, vetted clinical providers like ourselves needs to achieve this, that helps us. So I think we're eager to see it. We do have patients who, especially in certain patient populations, are even more skeptical. So we love when we could say, no, this is, really vetted and carefully curated data, especially when the news is full of all these data leaks and breaks all the time. So we're proponents, I would say.
And maybe I'll just jump in, and I'm a former FDA, so that's an important context for all of my comments today. But as you alluded to, Congress and FDA have made it very clear that cybersecurity is foundational to medical device safety and effectiveness, and that goes beyond privacy considerations to considerations around securing critical infrastructure in hospitals and other issues. But privacy considerations are certainly part of it, and I think that similar to how there was a reckoning around cybersecurity in healthcare over the last decade. We are probably approaching a reckoning around privacy in healthcare in the next decade in the context of these technologies. On the one hand, we need this data to train algorithms to address issues around clinician burnout, to help make sure that clinicians are able to spend the time they need one-on-one with the patients who need more time one-on-one. And so there's incredible value in this data, and we have to find ways to leverage that to improve the healthcare system. And still, we absolutely need to respect that this data, is from and belongs to the patients who generated it. And I think that from their perspective, whether it leaks because of an exploited cybersecurity vulnerability or because of an exploitative privacy policy or data sharing agreement, either way, the outcome is unacceptable. And it's something that we need to really look at carefully here as we move forward.
Absolutely. And I think with that, it would be great to turn over to some of the questions from our audience. Just as a reminder, audience members may submit questions using the YouTube chat function and through X, formerly known as Twitter, using the hashtag BPC Live. So we already have some really interesting questions coming in here. I think let's start with this one. So we are a group of 25 mobile wound care providers traveling to the skilled nursing facility and the patient's home, but we are struggling with implementation due to the lack of patient engagement. So what are your thoughts on this challenge? Atif or Devin, maybe one of you could grab this one to begin, and then of course we'd love to hear all your thoughts.
Devin, you want to go first, or
Sure.
yeah,
It's up to you, Steve.
go ahead.
Sure. Honestly, when I started reading that question, that was not the end of it I expected, because it's such a great use case. Wound care at home and all of those kinds of things. We are very excited about deploying the technology there because it's a big win, right? Wounds are difficult to take care of. The home care people, nurses and other folks are just working real hard trying to get all that information into the system. So lack of patient engagement, I think in that case, I'd really want to know more, to be honest. It could be that, the technology barriers, like I've talked about, there could be trust barriers. It depends on the communities they're really engaging with. But in general, when I make the pitch to folks, I mean, it is important. Any change comes with a little fear, right? So you do need to sort of make a pitch. I do it in my practice, right? I'm saying, listen, I know it's something new for you to have this technology at home. You're gonna have to figure it out. It's always a hassle, whatever. But here's what you get. And if you really make that clear, like you're gonna get someone looking at your information more carefully, you're gonna get to where you want to be controlled faster. And you're gonna have to take less, like 3 bus transfers from Queens to Manhattan to do it. That usually gets them where they want to go. So I don't know in the setting of wound care where these mobile nurses folks are working. But usually that kind of conversation will help clear those barriers.
So I would love to jump in here because Medicare doesn't cover wound care. And this is in the report. Specifically, we talk about this because there are good data showing that this works. And it is just not one of the, categories that Medicare has set up. And so even though the studies we've seen showed better outcomes and cost savings using these wound care RTM programs, they're not covered. And so there's another example of where we're just not utilizing technology that would really help folks.
Mm-hmm. Right. And, kind of, oh, sorry, go ahead.
The only other things I wanted to add here are again, I don't know the exact circumstances here, but the other place where some of these patients were in skilled nursing facilities. And it was a question about patient engagement, but I also just want to acknowledge that in a setting such as a skilled nursing facility where staffing is often very limited and there's a lot of demands on time, we're seeing that it's often difficult to introduce new technology because people are so busy. And I think it really does emphasize kind of one of the points where we started, which is that I feel like technology is only 5% of the issue, and it's 95%. How do we change clinical practices, build this in the time that's necessary, and just restructure things in a way that you can support this. And I think the other aspect of the question really prompted for me is this takes time. It's not easy to do quickly.
Right, absolutely. And I do want to just spend a little bit more time on the question of RTM. As you mentioned, wound care is not one of the services being covered under these codes at the moment. So how is RTM being used today, and how is it not being used? Kara, do you want to kick us off here?
Yeah, when we talked to experts, we found that RTM is not being used nearly as much as it could, particularly in the cognitive behavioral therapy space. And Devin can talk a little bit more about why billing, might be missing some of these. But again, this is a place where we think that this tool may be underutilized. And I think that perhaps the idea that Medicare has these very discrete categories right now. And right now that makes sense because we're still building an evidence base. And so keeping those separate makes a lot of sense. But I think it'd be great to have more options to be able to introduce new tools, and with these potential guidelines that we discussed earlier, encourage more providers and patients to use them.
Right. And this kind of ties into another audience question that just came in, kind of on the question of billing. And maybe Devin, you could take this one. What are your thoughts on combining RPM and RTM codes for Medicare patients?
I'm generally for it. I haven't yet sort of identified why I wouldn't be. I know people ask that question a lot, and I'm sure there are when we get to actually doing it. But to RTM in general, which has been a minority player compared to RPM, for multiple reasons. And you mentioned the cognitive behavioral therapy. Well, that dovetails into the lack of parity in coverage for mental health services broadly, right? And because of that, you can imagine that something that's tied to that then essentially gets less sort of the limelight. And even true of physical therapy services as well, which are much more distributed, right? A lot of healthcare systems, a lot of our patients live all over the place, and they're going to a local physical therapist, right? So there's this, it's less tightly connected to our healthcare delivery system. But again, if we reduce some of the overhead required to figure out, how do I bill for RPM and RTM separately and combine them and make it more unified, that's just going to take away what we would say in the industry, a friction point. And by removing that friction point, then you can focus on what's the next challenge we have to getting, if we think that the evidence is there and follow the science, as Kara said, to getting that out to the people.
The one thing I'd add here is that we've talked a lot about the devices, which are obviously critical in transmitting the information, but the payment models are often focused on the time that the clinician spends reacting to the information. So I just wanted to make sure that that was clear here and emphasize, which is that if we just send a lot of information over the transmit, no one acts, then we're not helping anybody. So it is really about using that information, identifying places where care can be improved, then we're talking here. And so as this industry evolves, I imagine we will start to see some coming together of the codes. And again, with a focus on how much time was spent this month, the payments are usually on a monthly basis, spent on that management for whatever chronic condition it was and whatever information is coming in.
Yeah.
And
We're
absolutely.
definitely going to rely on policy folks like Steve and everyone else on the phone to figure that out. I think for us, what we'd love to see when we think of the 16 data points a month, that kind of like sort of an antiquated model for what an RPM was 10 years ago. But if we really think about, hey, and I really like how Brandon was talking about sort of maybe even for the chronic disease we're doing well, like what is the purpose of RPM, right? It's really promoting health and reducing sort of the work of being a patient. And so like, how do we put the least burden on our patients possible and get them to the goal as quickly as possible in a safe and effective manner? Then have policy support that goal.
And speaking of support from policy, we have just a little bit of time left in our panel discussion. So I do want to ask you all one final question to close us out. So if you could have Congress or the administration do one thing to improve remote patient monitoring technology or the application of these technologies, what would it be? Brendan, why don't we start with you and then we can go to the other panelists.
There are a million good ideas out there, whether it's improving sort of CMS's understanding of what medical devices they can reimburse for, including those medical devices that don't include hardware, issues around these codes. There's just so many good issues, but I've got to go to the basics. We have portions of the federal government that are operating basically in limp mode right now, budget cycle to budget cycle. we're not going to have the bandwidth to think about any of these complex, difficult issues if we can't get a budget for the year. And so I'm going to zoom way out and say, let's get our federal agencies funded for the year so that people can think beyond a 3-month time frame and really start to make progress on these issues.
Fantastic. Kara, go ahead.
Sure. So again, I think that I think policy should follow the science. So I think doing more to figure out the utility of these tools and making sure that policy follows that would be first on my agenda.
Great. Devin?
Although I have all those policy desires, I will put that aside as the non-policy person and go a different direction, which would be, sort of cost of the transmission of data, but the usability. And what I mean is not just for the patient and the provider, but literally the whole journey. How easy is it from the minute it, shows up in my house to get into my doctor's hands? That should be a metric that we have a standard for. And if it can't achieve that standard, honestly, even if you're accurate, it shouldn't be cleared.
Absolutely. And Atif?
Lots of choices here, but you asked for one. I might build off of one of the ideas that Kara raised earlier, which is that a lot of the benefit, I think, from this technology comes early on. Right now, and so it's really shifting the paradigm from a model, which is I'm going to keep people on remote patient monitoring indefinitely, to almost this is a technology and a framework that's almost like a boot camp. We have an issue that needs to be addressed, wound care, uncontrolled high blood pressure, uncontrolled diabetes. We're going to use this technology aggressively to get things under control in a 6-month, 9-month manner. And then we move back to where we were previously, as opposed to where the current paradigm seems to be that you get someone on remote patient monitoring and this is a lifelong thing.
Right. Well, it's, the beginning of a new year, or at least close to the beginning of a new year. So let's hope each of these wish list items, move into action in 2024, and we see some movement ahead in all these areas. So with that, thank you so much to Devin, Atif, Brendan, and Kara for joining me in our panel discussion today. To learn more about BPC's work and their latest report, The Future of Remote Patient Monitoring, go to BPC's website at bipartisanpolicy.org.